All right, guys, so this is going to cover Chapter 19, which is fluid and electrolytes. Certainly, fluids are very important. They're in all of our cells. They're throughout our entire body. So we need to have a discussion on those. They're about 2/3 of their body weight consists of water. So we're going to talk about water, where it is, how does it move, those types of things. And then the real big piece is going to be the electrolytes and the acid-base balance. So we do have different fluid compartments. Okay, we have intracellular fluid and we have extracellular fluid. Okay, most of the body's water, about 2/3 of it, resides inside cells. That's intracellular fluid. The rest is called extracellular fluid, so it's outside the cells. This is tissue includes fluid between cells, which is interstitial fluid, as well as fluid within vessels such as blood, plasma, or lymph. We also have some other extracellular fluids called transcellular fluids, and those are things like cerebrospinal fluid, synovial fluid in the joints, different fluids in our eyes, and different digestive secretions. But 2/3 of our fluid inside the cells, intracellular fluid. Fluid moves based on osmolarity. Okay, osmolarity is the amount of solutes in a liquid. Okay, so here it's kind of showing you that fluid will move from intracellularly to extracellularly and the opposite way as well, really trying to create this particular concentration of solutes and concentration of water. So what this is showing you here is if the concentration of electrolytes, therefore the osmolarity of tissue fluid outside the cells, increases, water moves out of the cells and into the tissues. That's shown in the figure on the left. If the osmolarity of tissue fluid declines, water moves out of the tissues and into the cells. Okay, this passage happens very quickly, within seconds, to maintain equilibrium. So it kind of makes sense that if the osmolarity out here increases, less water out here, more water in here, water is going to move outside the cell. Here, osmolarity goes down, which means there's more water out here, less concentration of solutes, water is going to move inside the cell. Intake and output, you've probably had this conversation a little bit already, so we're going to move through this pretty quickly. But normally the amount of water gained and lost by the body each day is equal, about 2,500 milliliters of fluid. Most fluid intake occurs through eating and drinking. The cells do produce some water as a byproduct of metabolic reactions. And then most fluid is lost as urine, but we also get some as feces, some as sweat, and some through the lungs. But the biggest piece here is that it should be equal. If it's not equal, then we get some out of balance of our intake and output. But we do have a way that we regulate this. So as the water loss varies, we have a way in which we maintain this balance. So we have mechanisms to increase intake. So physical changes stimulate the thirst center in the hypothalamus, telling us that we're a little bit dry, okay? So it tells the hypothalamus that we're thirsty. Salivation decreases. We get this dry mouth, okay, and thirst. That thereby alone makes us consume water. So it's our kind of our own mechanism that does this. There are certain things that are going to cause the stimulation to get to the thirst center. Things like excess sweating, our blood pressure drops, sodium concentration rises, or osmolarity in our blood, or the concentration of solutes in our blood rises, causing us to be in a state of dehydration. What mechanisms we have also to decrease output? So physical changes, again, stimulate the hypothalamus. Again, things like decrease in blood pressure and increase in osmolarity. This stimulates the posterior pituitary to secrete ADH. ADH prompts the kidneys to reabsorb water and produce less urine, so we hang on to more fluid, thereby increasing, the amount of fluid we have circulating. So what does it mean if we have a fluid deficiency? They can refer to that another term of volume depletion, results from blood loss or loss of both water and sodium. Dehydration results when the body eliminates more water than sodium. Both of these things are going to cause us to be fluid deficient. Here's a little diagram showing you what happens during dehydration. So number one, we get water is lost through sweat. Okay, that's how we lose more water than salt because the salt can't really follow it as much. Fluid from the bloodstream furnishes the sweat glands. Fluid shifts from the tissues into the bloodstream, and fluid shifts from cells into tissues. So we get this dehydrated state. So in dehydration, because of loss of fluid, the concentration of sodium and the osmolarity of extracellular fluid increases. The fluid within the vascular system. The increase in osmolarity prompts the shifting of fluid from one compartment to another in an effort to balance the concentration of sodium. This is what happens when we have excessive exercising or excessive sweating. Also can happen when we take too many diuretics or in cases of diabetes. We also can get then fluid volume excess. Usually the kidneys can compensate by producing more urine, but sometimes we can get too much. It's not very common. Usually we have a fluid deficit. One causes renal failure though, because then the kidneys aren't able to compensate and produce more urine. Another is water intoxication. So it's someone consuming an excessive amount of water and the kidneys really just can't keep up, and it really causes an imbalance in the amount of electrolytes. Usually then we get some pulmonary edema or some cerebral edema. So we get some swelling in the lungs or fluid in the lungs and some swelling in the brain. So again, not very common, but it can happen. We also then can get fluid accumulation, okay? This involves the accumulation of fluid between compartments, so really interstitial or tissue fluid. It can really accumulate in any organ or tissue, but usually the lungs, brain, or dependent areas such as the legs. And it shows itself in edema. So we can see this pretty commonly in people's lower extremities. So you'll want to make sure that you're assessing your patients for these things. We'll talk more about that later on in the course. So let's talk about some electrolytes. Electrolyte balance certainly is very, very important. Electrolytes drive chemical reactions. They affect the distribution of the body's water content and determine a cell's electrical potential. So all very important things. The major cations are sodium, potassium, calcium, and hydrogen. So those are those abbreviations there. You can see that the cations are all positively charged ions. And then the major anions are chloride, bicarbonate, and phosphorus. And those are all negative ions. Let's talk about each one of these quickly, or a few of these anyways. Quickly, the ones that you really need to know. Sodium is the main electrolyte in extracellular fluid, counts for 90% of the osmolarity of extracellular fluid, determines the volume of total body water, because we said where salt goes or where sodium goes, water goes. So it certainly influences body water distribution, and it plays a key role in depolarization of neurons, and so then plays a role in nerve and muscle function. So how do we regulate sodium? This is what happens as serum osmolarity drops. Okay, so the serum actually gets more dilute. The aldosterone prompts renal tubules to reabsorb sodium, so we want to add more sodium to increase the osmolarity. Antidiuretic hormone is suppressed, so the kidneys secrete water, and serum sodium levels increase. So aldosterone and ADH are the main players here that can control the sodium. So this happens when sodium levels drop, or when osmolarity drops. When sodium levels go up or osmolarity goes up, aldosterone prompts the renal tubules to reabsorb. I'm sorry, that shouldn't. All right, guys, so there was actually an error on that slide. So the second bullet point I want you to just take right out of there. Doesn't play a role here. We're really just talking about ADH. Okay, so this is when we have too much sodium. We have increased osmolarity. Antidiuretic hormone causes the kidneys to reabsorb water. Antidiuretic also stimulates thirst. So we're going to take in more water, and thereby we're going to dilute that sodium level and bring it back down. So we do have sodium imbalances, so you will need to know these values. Normal value is 139 to 146. You might see some places 135 to 145, but it's close to this range. So hypernatremia is too much sodium, so sodium concentration greater than 146 indicates a fluid deficit. So our blood or our plasma is too concentrated. Usually we can correct this by triggering thirst. We drink, and we're going to dilute that back down. If we have hyponatremia, usually this is going to result from excessive body water, and usually our kidneys can correct this by getting rid of more water, but certainly there are times at which that does not occur. We also have potassium imbalances, so you need to know 3.5 to 5.0 is a normal potassium range. Hyperkalemia means potassium greater than 5, can occur suddenly or gradually, and what really happens here is we get nerve or muscle cells irritable. So you get some kind of spasming or twitching. Okay. Potassium is the chief cation of intracellular fluid. Okay. It works with sodium for nerve and muscle function. And aldosterone can really help to regulate serum levels of potassium, just as it does sodium. So again, that's another key player here. Hypokalemia is a concentration less than 3.5, can result from diuretics, get rid of too much potassium, too much vomiting, or chronic diarrhea, and it makes the cells less excitable. Potassium is really important because it can play a big role in cardiac arrhythmia. So too high or too low, and we can get some deadly cardiac arrhythmia. So we always want to make sure that people's potassiums are within an appropriate range. Calcium is our next one. So we have hypercalcemia, greater than 5.8. Hypo is less than 4.5. Hypercalcemia can result from hyperparathyroidism, hypothyroidism, or alkalosis, and it really inhibits depolarization, which leads to muscle weakness, depressed reflexes, and cardiac arrhythmias as well. Hypocalcemia is less than 4.5, can result from the opposite things there. So hypoparathyroidism, hyperthyroidism, acidosis, or diarrhea, and increases the excitation of nerves and muscles. So we get muscle spasms and something called tetany, which is kind of almost like a spasm in. The last part here, and probably the most difficult piece of this chapter, is acid-base balance. But it's so important that we talk about it because if you think back, we remembered that the pH of blood ranges from 7.35 to 7.45. It's really important that our body works really hard to keep it inside that range. Even slight deviations can cause a lot of issues. So we're going to talk about how many systems play a role in this, but the kidneys are kind of one part of that. So that's why we're going to talk about it here. The very first thing that happens when we get the pH of the blood rising or lowering is the buffer system kicks in. It happens within seconds. It's happening kind of all the time in our body. A little bit here, a little bit there. It's the first thing that's going to control pH balance, okay? So what happens is we can use a weak base to bind hydrogen ions. Hydrogen ions mean acid, okay? So if you see hydrogen ions anywhere, that means acid. They're free floating around. That means we're more acidic. If we're picking up hydrogen ions and getting rid of them or binding them to something, we're going to make that solution more alkaline. So in buffer systems, there's bicarbonate buffer system, phosphate buffer system, and protein buffer systems. But all three systems are working kind of all the time. And really what they do is they use a weak base to bind a strong acid or hydrogen ions. They kind of neutralize it and make a weak acid. Or they can do the opposite. They can take a weak acid and bind to a base and they can, a strong base, and they can make a weaker base. So either way, they're kind of buffering these strong acids or these strong bases to help make them have less of an impact or less of an effect on the pH of the blood. That's why they're called the buffer systems. You can see in your book, there's a whole bunch of chemical reactions here. You don't need to know that. What I would do, just know, is that we really are taking and neutralizing a strong acid or a strong base. And that's really the point of the buffer system. And also you need to know that it's happening. It's kind of the first part of the 3 different systems that play a role in acid-base balance. And it happens all the time, and it's happening very quickly. The problem is it ultimately will run out. We'll run out of buffer systems. So we have to have other things that kick in, okay? And these are our respiratory and our urinary systems. So our lungs, in a very general sense, expel carbon dioxide, okay, which also is acidic, to lower pH. And the kidneys can expel hydrogen ions to lower pH. So they both can play a role in pH balance. The respiratory system does this by detecting a decline in pH. So we have chemoreceptors in the brainstem detecting a decline in pH from an accumulation of CO2. So our blood is becoming more acidic. They signal the respiratory centers to increase the rate and depth of breathing. The lungs blow off carbon dioxide. Less carbon dioxide is available to combine with water to form carbonic acid, and the concentration of hydrogen ions decrease and the pH rises. Okay, so that's what I mean when I said CO2 is acidic. Okay, so if you're always talking about CO2, just remember that it's acidic. Okay. Sometimes the respiratory center plays a great role in helping us with pH control, but also if the respiratory system is not functioning appropriately, it can cause some problems with pH control. So if we have somebody who has an acid-base balance, we probably are going to look to their respiratory system to see if that's actually what's causing the issue. pH control from the renal standpoint or from the urinary standpoint, we can tell the kidneys to get rid of hydrogen ions and reabsorb more bicarbonate. So we're going to get rid of more hydrogen ions, which is going to decrease the acidity or increase the pH, and reabsorb more bicarbonate ions, which are basic or alkaline, and again, increase the pH. The renal system is the most powerful buffer system, but it's also the slowest to respond. So we talked about these kind of order of response time. The chemical buffer systems are going to happen first, happen very quickly, but run out very quick. So if we still have a pH imbalance, the respiratory system is going to kick in next and either increase its rate of breathing to get rid of CO2 or decrease its rate of breathing to hold on to CO2. And then the respiratory system can't do that forever. So eventually, within some hours, the renal system will also start to control acid-base balance. Let's watch the only animation on this chapter.
When carbon dioxide increases, so does the concentration of hydrogen ions. This causes the body's pH to decline. The renal system works to expel hydrogen ions from the body, while also reabsorbing bicarbonate. This makes the renal system the most powerful of all the buffer systems. Carbon dioxide leaves the blood and enters cells along the distal kidney tubules. In these cells, carbon dioxide combines with water to form carbonic acid, that is, H2CO3. The carbonic acid immediately dissociates to yield hydrogen and bicarbonate ions. The hydrogen ions diffuse out of the cell and into the tubular fluid, where they displace sodium. The displaced sodium diffuses into the tubular cell, where it combines with the bicarbonate to form sodium bicarbonate. Sodium bicarbonate is then reabsorbed into the blood. The end result is that hydrogen ions are excreted into the urine, making the urine acidic, whereas sodium bicarbonate is reabsorbed into the blood. Both actions help increase plasma pH.
So hopefully you can see the 3 different ways in which we control pH, okay? They're more complex, so really spend some time looking at this in your book and seeing these 3 processes, because you definitely need to know the 3 different processes. The last couple of slides I want to talk about are acid-base imbalances. So what happens when we actually do get an imbalance? So we can have a respiratory imbalance resulting from an excess or deficiency of carbon dioxide. And then we can have a metabolic imbalance, right, resulting from an excess or deficiency of bicarbonate. Okay, so here's a little table that shows you these things. So if we have what's called respiratory acidosis here, okay, that's happening because we're getting a retention of carbon dioxide. So we have too much carbon dioxide and it's making our blood acidotic. This happens from hypoventilation, so things like emphysema or pneumonia, as well as apnea, so we're not breathing. For some reason, our respiratory system is not getting rid of carbon dioxide. That results in our blood becoming acidotic, less than 7.35. We also have then respiratory alkalosis. So this is too much loss of carbon dioxide, and this usually occurs from hyperventilation and is fixed very quickly. Anxiety attacks, panic attacks, pain, anything that's causing that respiratory rate to be elevated for a period of time so that we're getting rid of too much CO2. If we can treat this and just control the respiratory rate and bring it back down, we'll increase the amount of CO2. That's why when people are having panic attacks, they tell them to breathe into a bag so that they're actually rebreathing in their carbon dioxide so they don't get rid of too much. The other side of that is we can have metabolic acidosis or metabolic alkalosis. Metabolic acidosis results from an increased production of acids. So we get ketone bodies in patients who are diabetic or lactic acid production. Also can get this from a consumption of acidic drugs such as aspirin, or the kidneys are no longer able to excrete hydrogen ions. So we have an issue with the kidneys. Or a loss of bicarbonate, such as with chronic diarrhea. So our GI tract is getting rid of too much bicarbonate. Metabolic alkalosis is not really all that common. It would only happen if we got rid of too much gastric juices. Our gastric juices are very acidic. So if we had somebody who was chronically vomiting, or we were chronically suctioning out all of their gastric juices, or they took way too many bicarbonates, which are antacids or TUMs, and they made themselves alkalotic. Okay, so alkalosis means pH 7.45 or greater, acidosis 7.35 or greater. Okay, and this is an impairment with one of our normal systems that plays a role in pH balance. That's how we get an impairment. Okay. What happens is when we have an impairment, we can actually get some compensation for this from the other systems. So if we have a metabolic acidosis or alkalosis, our respiratory system can respond to this by breathing more or breathing less, right? So if the pH is becoming too acidotic, then we're going to get a patient who's actually going to breathe more, right? Because the respiratory center can get rid of CO2, which is going to decrease the amount of acid in their blood. So you can get that going both ways. Also, then we can get the renal system, which can help to compensate as well by adjusting the rate of hydrogen ion excretion. So we can get multiple things there to do that. The kidneys really are the most effective regulators. But again, remember, it takes a while to do that. So they can either eliminate hydrogen ions or conserve hydrogen ions. And the respiratory system can either get rid of more carbon dioxide or hang on to more carbon dioxide. So you can see that both are going to play a pretty significant role in compensating when we get some sort of imbalance.